Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Good day to all attendants in this meeting, wherever you are. First of all, I would like to thank to the organizing committee for inviting us from IRAS, Indonesian Radiation Oncology Society, to talk in this important scientific meeting. Here is, as you know, that the distribution of the head and neck cancer based on the location. And in this very special occasion, I'd like to take some time to explain how is now the progress of technology development of radiotherapy that could be used in the field of head and neck cancer treatment and improve, of course, the treatment result of head and neck cancer. Just to remind us that cancer treatment is not survival of the fittest, but should be evidence-based treatment with the goal is not just treatment response but also the quality of life, and should be mostly multimodality treatment based on the pathological findings, location, and states of the disease. Again, to remind us, there are three groups of treatment. The evidence-based treatment group of treatment that have enough data and have passed several steps to prove their efficacy and side effect by scientific method of analysis. For example, in this group is surgical, systemic treatment, as well as the radiotherapy. The novel treatment, group of treatment that have a scientific background but still have not enough data to prove the efficacy and side effect, and usually are under the studies. And the third group are the complementary alternative medicine, the non-medical treatment, those has no scientific background at all. Just to remind, be careful with the second group since that there are more and more materials under the studies right now, almost more than 3,000 different kind of anti, as long as it is involved in the signal transduction pathway process, and also from the immunology point of view. We have to be sure that the modalities and medicine that we use in the clinical setting are already past all of these procedures. It is the outline of my talk. When irradiation is attack the biological material, so ionization process will be happen either in the as a direct effect when it is happen in the DNA, or indirect effect when it is happen in the water molecule. So we'll produce the free radicals. Then P53 will be regulated when there are cells with their different level of DNA damage. From the simple one like protein-protein cross-link to the very severe one. So, for example, double-strand break DNA. Then the cells with DNA damage will be blocked in G1 phase of proliferation and giving time for the repair genes to repair all the DNA damage. If the repair can be completely, no more damage, so the cells are allowed to continue doing the proliferation. But if not, the cell will be sent to program cell death, so-called the apoptosis. This process is really important to be understood, especially when we want to do the chemoirradiation. Combine chemo concomitantly with irradiation as a radiosensitizer to get a good result or better result of the treatment. And also, it is important to be aware that this will be happen not only in the area of target irradiation, but also in the pathway of irradiation beam when it goes to the target area. That means the normal tissue surrounding the target. So the state of the art of radiotherapy is how can we give the high curative dose, high impact of irradiation to the target without impact to the normal tissue surrounding of the target. That's so-called the good therapeutic ratio. To achieve a good therapeutic ratio is a main goal of milestones technology development of radiotherapy, which is in line with the development of radiology imaging from 2D, 3D, such as CT, MRI. So we also doing the 3D conventional radiotherapy or 3D Imrt, even to tomotherapy. Then in the era of 4D imaging, we also doing the 4D radiotherapy, 4D adaptive radiotherapy. Even we also have to face the heterogeneity behavior within the tumor that we can get the information from the theranostic imaging like PET-CT, as well as we have also to face the problem of internal movements such as respiration that will move the target of irradiation. So the main goal of radiotherapy is to find the target of irradiation inside the body. And our main purpose as a radiation oncologist is to sculpt the beam, the dose of irradiation exactly to the shape of the irradiation target. And nowadays, it is 100% possible with the technology called the intensity modulated radiotherapy. Even to solve the heterogeneity behavior within the tumor or target, we can do the so-called the dose painting. And to solve the problem of internal movement, we can use the 4D adaptive radiotherapy or image-guided radiotherapy. Just an example, the purple area is the tumor. And if we do the 2D technique, so the blue area is the area within the body that will also get the curative dose. Blue area outside the purple are the normal tissue that will have also an impact of such a radiation dose as a side effect. The curative dose area is reduced when we use the 3D conventional radiotherapy and when we use the intensity modulated radiotherapy technique. So the curative dose area will exactly close to the target of irradiation. So-called the conformity index is close to 1. That means very little normal tissue will get an impact of high dose of irradiation in the target area. So that's a good therapeutic ratio. Intensity modulated radiotherapy that is more advanced is so-called the rapid arc or volumetric modulated arc therapy, which is the gantry and the collimator are moved around the patient or the target. The benefit is that the time of irradiation will be less. That's a very important for the precision of irradiation. This is one type of OLI neck, just operated like CT scan, so-called the tomotherapy. With this machine, we can get an amazing dose distribution. For example, we can do the whole brain irradiation for brain met with hippocampal sparing, since we know that hippocampus is a very important organ for quality of life of the patient. We can do also whole cranial for cranial mets with a very low dose of irradiation in the brain inside. We can do also even the whole skin irradiation, for example, for cutaneous lymphoma, and also the whole abdominal irradiation with sparing of the, for example, one kidney is the normal kidney. And this is the tomotherapy in our hospital. Until now, is the only one in our countries. Cone beam CT is a very important part of radiotherapy process. It's an immediate verification of the irradiation machine before the patient is irradiated. So we see before we treat where is our target. We'll see more about this cone beam CT later. This is how we face the problem of internal movement. For example, in the left lower picture, you can see the green circle in the radius is the radiation field. We can include the movement of the target. So the radiation field, the green circle is bigger. Then you can see in the number 2 picture, when the radiation is only on when the target is inside the radiation field. This technique, we call it as the respiratory gating. And so-called the respiratory tracking, when the radiation field follow all the movement of the target. The different size of a radiation field, that means the different size of normal tissue that include in the radiation to the target with the risk of increase the side effect. In this case, that the target is close to the organ at risk or critical organ, for example, the medullary spine, or we face the case with the slow-growing tumor, for example, acoustic neurinoma or schwannoma that is not response to the normal conventional radiotherapy, as well as other non-neoplastic disease such as AV malformation. We can do so-called the stereotactic radiosurgery with the level of accuracy very precise using the rigid G-frame that attach to the cranial bone, and we give high single dose. How high the dose is depend on the size, location, and kind of the target. So with this technique, the biological cell death effect is different than the conventional radiotherapy due to the single high dose, and we can treat the tumor located close to the critical organ. And if we do outside of the brain, we call as the stereotactic body radiotherapy using the very precise immobilization device with vacuum blood bag. For example, we can irradiate the case of vertebral mats just a part in the vertebral body with the high single dose. This is how we treat the patient in our equipment in our hospital. So here is the step of evolution of radiation oncology development. First, how to sculpt the beam or the dose, and then the how to immobilize the patient, and then how to deliver the to the right location of the target. The final that's still ongoing to be installed in Indonesia is the proton therapy. Here is the curve percentage deep dose in the right graph that we will talk about this later. This shows you schematically how it works, the combined treatment radiotherapy and chemotherapy concomitantly as a radiosensitizer. Can be as a supraadditive or subadditive, can be spatial if it works in the different biological mechanism, or synergic effect if it works in the same biological mechanism. For example, the synergic effect when we use combined treatment radiotherapy with the taxane group. The taxane group will do G2M arrest of the cells, since that the radiotherapy works mostly in G2M phase. So by combining them, it will increase the radiotherapy effect, or the treatment result will be better. This, for example, if we combine radiotherapy with the capecitabine, that will impair the repair mechanism. So all the damaged DNA due to irradiation will go to the programmed cell death or apoptosis. These two examples are the good radiosensitizer with synergic effect that will increase the result of the treatment. Now let's move to the second section. As we know that head and neck cancer has to be approved differently because there are many small and delicate organs in head and neck region that serve various functions, from chewing, swallowing, breathing, tasting, smelling, hearing, speaking, until expressing. And head and neck cancer itself almost leads to disturbance of those physiologic function. And the treatment also leads to further disturbance of physiologic functions. This can lead to the debilitating condition and poor of quality of life. So that's why we need to improve the way of the treatment head and neck cancer to decrease its toxicity. You can see here that if a patient survives from head and neck cancer, its treatment eventually leads to a long-term physical deficit. Some of these deficits are associated with the treatment for radiotherapy or concurrent chemo-RT. That's why specifically in terms of radiotherapy, we need to improve the way we deliver radiotherapy to decrease the toxicity and possible also to improve the outcome. Radiotherapy, as we know, is a very important modality in the treatment of head and neck cancer. Radiotherapy has a role in almost all stages of head and neck cancer treatment, from the definitive treatment, adjuvant, until the palliative treatment. This graph shows the distribution of metastatic sites from the head and neck cancer. The most common site of metastatic for the SCC of head and neck cancer is lung, while the most common site for the nasopharyngeal cancer is in the bone. Specifically for nasopharyngeal cancer, this is the disease entity that is very rare in Western country, but it is endemic in majority of the Asian population. And specifically for nasopharyngeal cancer, the treatment of choice is radiotherapy or radiotherapy combined with chemotherapy for definitive treatment. So availability of radiotherapy truly dictates the success of nasopharyngeal cancer treatment. Radiotherapy has been an important part of head and neck treatment for decades, even since the era of very simple radiotherapy technology, as we already mentioned before. With the 2D radiotherapy, conventional radiotherapy, you can see here on the left of the dose planning of the 2D radiotherapy. The dose was similar across the treatment cross-sectional, which means that the normal tissue or organ nearby of the target also receive similar dose as the dose to the target. On the middle is the 3D radiotherapy. Here you can see much more sparing of nearby normal tissue. This leads to a much lower toxicity, for example, less xerostomia and less mucositis and so on. And with the Imrt now more readily available in more and more radiotherapy centers, toxicities are even less because we can reduce even further dose to unnecessary normal nearby organ. This was an example of cone beam CT. This cone beam CT was taken before patient was given radiotherapy treatment, so each day. The purpose of this cone beam CT is to ensure that the target of the treatment is proper and accurate placed, so we don't miss the target. This is an example of incorporation of the PET-CT into the radiotherapy treatment. The patient was acquired a PET-CT image as the basis of radiotherapy treatment planning. Patient was immobilized with the radiotherapy immobilization device and PET-CT was acquired. And this can truly aid the delineation of the target of radiation, thus minimizing the risk of missing part of the tumor. Furthermore, with the Imrt or Imrt, now we can escalate radiation dose toward the particular structure. For example, the structure that has the higher SUV update receive the higher dose. This is called the SIB plan, simultaneous integrated boost plan, or we can also the dose painting. This can possible increase tumor control by radiotherapy. This is the radiotherapy planning comparison of same patient with the different radiotherapy machine. The left one is using helical tomo, the second one using the Imrt plan, and the third one is the Imrt plan. And the fourth one is the 3D CRT plan. You can see that with this helical tomo, the radiation dose spillates toward the normal organ or slightly smaller compared with other plans. This again can lead to less toxicity associated with this radiotherapy treatment. As well as this also comparison of different radiotherapy plan, both tomotherapy and Imrt are actually rational arc radiotherapy, but they accomplish the treatment slightly different. You can see here that the plan are quite comparable with low dose, slightly less in tomotherapy plan. Another form of advanced radiotherapy is Sbrt, Stereotactic Body Radiotherapy. This Sbrt delivers high dose per fraction in only limited number of fractions, generally 5 to 8 or let's say below 10, to a small confined target. Sbrt is increasingly used for the relapse of head and neck cancer of previously irradiated site. Even it deliver a high dose per fraction, but due to the technology advancement, it can minimize the dose to the surrounding normal tissue. This is accomplished with the at least Imrt technique. And because this treatment required a very high accuracy, then a cone beam CT is compulsory. This is an example of Sbrt treatment of certigrade in 5 fractions that refer to a locally relapsed oropharyngeal cancer. The MRI and PET scan was used to improve the visualization of the tumor target during delineation. You can see after the Sbrt treatment, the MRI post-treatment showed complete response. So this advanced form of radiotherapy has to be considered in case of locoregional relapse of head and neck cancer treatment. This is a diagram showing the workflow of next generation of radiotherapy. As radiotherapy treatment is being given in multiple fractions, especially in definitive setting for head and neck cancer, it can be up to 33 to 35 fractions for 7 weeks. Then there must be slightly anatomical change over the treatment course in those 7 weeks, right? There are probability that patient lose weight or the tumor shrink. All those affect the radiotherapy dose distribution received by the normal organs. To compensate this anatomical change that happen during the course of treatment, we can now capture those changes daily before the treatment and make necessary radiotherapy plan adjustment. This is called the adaptive radiotherapy, which is increasingly popular and might become the standard of care in the next few years to come. All those adaptations can only be accomplished with the aid of advanced radiotherapy software and hardware. And now that technology is already available in high-end Linux machine. Now let's review the clinical benefit of advanced radiotherapy in the treatment of head and neck cancer. This is the latest NCCN guidelines regarding radiation technique. You can see that the recommended radiotherapy technique is at least Imrt or the advanced form of Imrt, such as helical tomotherapy or Imrt. But if proton therapy is available, that it should be considered because the proton therapy can reduce the unnecessary dose to the normal structures, even greater than the most advanced form of Imrt. But unfortunately, as we mentioned before, proton is still very expensive and in Indonesia not yet available. So at a very least for head and neck cancer radiotherapy, Imrt should be the choice of the treatment. But hopefully soon we will install the first linear accelerator equipment in our countries. This was the prospective randomized study comparing 3D radiotherapy and Imrt for head and neck cancer. In terms of overall survival and progression-free survival, both radiotherapy techniques were comparable. But in terms of toxicity, the 3D CRT has much higher toxicity compared with the Imrt. You can see here the percentage of moderate to severe toxicity over the years were much higher in 3D CRT arm compared to the Imrt arm. So if we look at this benefit, we truly have to choose Imrt as the choice of treatment of head and neck cancer. This was another randomized clinical trial comparing Imrt with and the 2D radiotherapy for nasopharyngeal cancer. You can see here that with Imrt, all parameters, local control, regional control, and overall survival are favored to Imrt. And with the Imrt, both acute and late toxicities associated with radiotherapy was reduced significantly. You can see here most parameters were better with Imrt. The xerostomia, temporal neuropathy, cranial nerve palsy, trismus, fibrosis, all less in Imrt compared to the radiotherapy. Another meta-analysis of Imrt versus 2D radiotherapy for SCC head and neck cancer all conclusively show that Imrt was better in reducing the toxicity. This was a real case from one of my patients who developed metastatic to lung. You can see that the lung metastasis was nearby the bronchial airway, and further systemic treatment has failed to control its progression. Eventually, it leads to compression of the bronchus, leading to atelectasis of the right lower lobe. Then I give her radiotherapy with Sbrt technique, but only slight hypofractionation, use 15 to 2 time 2.5 gray, and I did daily cone beam CT on each day before the radio treatment. And you can see here on the fraction of 13, her atelectasis disappeared. This indicated that the airway obstruction was released and the patient clinically felt less dyspnea. This proved that the beneficial role of advanced radiotherapy in such case. Next, we will discuss a little bit what the future of radiotherapy may become. As we mentioned before, is the proton therapy that will be installed soon, hopefully in Indonesia. This is an example dose distribution using the best Linac VMAT Tomo versus the proton. Can be seen that the low dose irradiation in the normal tissue area is smaller using the proton. And as an impact that there will be the reduce of the side effect, you can see here for example for nasopharyngeal cancer, there will be 60% decrease the use of feeding tube as well as in the oropharyngeal cancer. That's the benefit using the proton treatment in case of head and neck cancer. Here is the picture of proton therapy. And with proton therapy, we can do the technique so-called the flash method. Flash is a ultra high dose of radiotherapy, extremely short treatment time, around 1 second, kill more cancer cells but greater sparing of normal cells. Now it is still under the phase 1 trials in human. Hopefully we can use it in the clinical setting soon. Finally, we conclude the take-home message. Radiotherapy is an important and indispensable part of head and neck cancer treatment. A lot of important organ in head and neck region that has important physiological role. The treatment paradigm today is not just kill the cancer cell but also need to limit damage. And radiotherapy has showed its ability to do so with advanced radiotherapy such as Imrt, helical tomo, and VMAT, and also the Sbrt. Those advanced radiotherapy technique is some of that become the standard of care for most of head and neck treatment case today. It is not just improve the curability but also reduce the morbidity. The future of radiotherapy may be proton and flash, and it is very exciting to see it actually become available in the near future. So thank you very much for your kind attention.